Okay, welcome to new question. We will discuss about the prolactinoma in this part. Recently asked in NEET PG 2 3 years before. Okay, they asked specifically the diagnosis level, the diagnostic level of the prolactin in such cases, and this was the around more than 200 microgram per liter. Okay, so apart from this, what are the important points in the prolactin? Okay, prolactinoma is the most common functioning pituitary tumor. Remember this, and DOPA. DOPA inhibit the prolactin. Okay. Uh, Next part is this. If someone is present with the elevated prolactin level in your OPD, you have to remember that you have to exclude a secondary cause of hyperprolactinemia, like the patient either have any pituitary mass. So you have to do MRI for that and rule out these causes. Okay. The important thing is that here that only and only it is treated if the patient is symptomatic. Mean important line is here that if patient have no symptom, if patient is asymptomatic and it does not affect her fertility or his fertility, then there is no need of treatment. Okay, so only in the symptomatic patient you have to go with the treatment. And if you see that in the microadenoma part, the microadenoma is defined less than 1 centimeter, and the macroadenoma defined by more than 1 centimeter. You in the both cases you have to titrate the dopamine agonist. If means if a patient is diagnosed with the microadenoma, the next therapy you will start is the dopamine agonist. In the both cases, either it can be cabergoline or bromocriptine. The drug of choice is cabergoline according to Harrison. And in the pregnancy part, you have to give the bromocriptine, and it should be stopped before lactation and 7 days around before lactation. I don't know about that thing. It is written specifically in some book. Okay. The important thing is after the macroadenoma is suspected, you have to see the visual field to see the baseline and also the pituitary reserve function to see that it does not causing very effective mass lesion in this. After then you have to titrate the dopamine agonist like twice in weekly you have to increase that and repeat the MRI within 4 months. Okay, if after repeating you see that the tumor is shrinking or tumor growth or persistent or hyperprolactemia is still there, no tumor shrinkage or tumor growth is still there or persistent hyperprolactemia, you can either change the dopamine agonist, repeat MRI, or consider surgery. For the part where tumor shrinkage is done, you can go with monitor prolactin and repeat the MRI annually. Okay. The important part is in this chart that you have to remember that the examiner can ask that only in the examiner can ask that in the only symptomatic prolactinoma you have to treat. There are two drugs available, cabergoline and bromocriptine. Drug of choice is cabergoline. Okay. Important thing is that important drug that inhibit the dopamine. Okay, if someone inhibit dopamine, prolactin will rise. Okay, so important drug that inhibit the dopamine and increase prolactin in the general use we use metoclopramide. Okay, the investigation for these things is screening for the fasting prolactin, and for the confirmation you have to do GD enhanced MRI, T1 sagittal and post contrast, and you compare for the micro and macro adenoma. The three important things, the triad of prolactinoma is amenorrhea, okay, galactorrhea, and infertility. You remember the galactorrhea? Why is there is galactorrhea? Because prolactin increase the formation of breast gland, and okay, and there is amenorrhea and there is infertility. Okay, this is all about this small topic prolactin.